So we'll start with the title. Hopefully many of you will actually get an idea of what the title's about.
Alice? Alice?
Rafe,
Oh, Alice, we can't go on like this.
I know it's madness, Rafe. Utter madness.
So you know.
Of course I know. In fact, I've known for some time.
You mean?
Yes. We're talking out of sync. Our lip movements do not correspond with our voices.
Our lip movements do not correspond with our voices. There's only one thing for it, Alice. Waiter, 2 glasses of Heineken, please. After you, my dear.
Well, you know that it's an old Heineken advert, and I don't know if you remember them or saw them in your part of the world, wherever you were. But Heineken used to have a series of adverts about refreshing the parts other beers don't reach. Interestingly, the advert was taken up by Health Education Authority, I think it was, who used them in health promotion, and they had a diagram slightly different to this one, where the arrow is a little bit more droopy, and they used to say that there's one part that every beer reaches, and they were trying to trade off the Heineken advert. Interestingly, though, that message didn't actually reach all parts, because some people were not aware of the Heineken ad, some people didn't know the symbol for male sex, and some people couldn't seem to put the two concepts together anyway. So it was interesting that particular message didn't actually reach all parts. And the aim of this webinar is just to discuss the evidence about accessibility and e-health. And accessibility obviously takes many forms. First of all, let me just say, if you want to post a question or comment as we go through, please do. But obviously I'm going to be concentrating on the presentation. Others may wish to respond to your comment or question, and I'll review the chat dialogue at the end of the presentation and then respond via this window here. Just another point about technical things. If you do freeze above the window, you'll see there's a reminder that if it freezes, you can press F5 to try and regain things if it seems to freeze. So, one more point about messages. When typing a message, try and preface it so that if it's for me, say Ray, but if it's in response to somebody else, say Paul, can you tell me what? Janet, I disagree with what you said, and so on. So, e-health accessibility comes in 2 forms really. First of all, there's physical availability. Can you get access to a computer, or nowadays it's the internet, either publicly or socially, or at home, privately, or at work. And then secondly, can you actually understand the information that's there? Have you got the strength to do it, the money to do it, the time, the skill, the knowledge, the mobility to make use of a particular source of information or service? Now, there are many myths that you come across, and I was at a conference a few weeks ago in London where one particular myth was brought out several times, and this is the one about mobile phones. And if you look on Wikipedia, you'll see that in Hong Kong the penetration rate reached 140% of the population in July 2007, and so on. Over 50 countries have mobile phone subscription penetration rates higher than that of the population. And of course, okay, we know what that is. That means that there are more mobile phones than there are people. But I've got a mobile phone sitting at home, not being used, so I've got 2 mobile phones, whereas other people haven't. And another speaker at the same conference on e-health in London said that more than 100% of the UK population have mobile phones. Well, call me a pedant, but I don't think you can actually have more than 100% of the population having mobile phones. You can have more phones than people, but that doesn't mean anything. If you look at a much more useful source of information, this comes from Ofcom. I think that's the right source. I can tell you the correct source afterwards. But if you look at technology ownership by age, you won't see the details there, but the left-hand column is digital TV, the middle column is the internet, and the right-hand column is mobile phones. And you can see that there's gradients there for by age for all these technologies. And if you actually look at ownership by age group, you'll see that digital TVs, 90% of people 25 to 34 have a digital TV, but over 75s it's down to 58%. With the internet, it goes from 82% in the 16 to 19-year-old age group down to 10% in the over 75. So only 10% actually have internet access. And mobile phones, only 42% of the over 75s have a mobile phone. It's the Ofcom Media Literacy Report. So when people talk about more than 100% of the population having mobile phones, it's actually a load of crap. And we should challenge people about these things. This is the internet access by age between 2000 and 2006. The top line, you won't be able to see the details particularly well, but the top line is 16 to 24-year-olds. The bottom line is the 65-plus-year-olds. And if we look at the internet access within the last 3 months, it was 93% of the 16 to 24-year-olds and just over a quarter of the 65-plus. That's based on a sample of 1,800 adults. So this is like good quality information that we can actually believe. So when people talk about things like mobile phone ownership and access to the internet, you need to make sure that you check with them what's the source of their data, what are the numerators they're looking at, are they unique individuals? For those of you who don't know, the robots and spiders, these are the things which crawl around the web and create hits on websites unless you manage to take them out of the web counting. There are standards for doing web counting on websites, but you need to check that the people, for example, who tell you that their website has had so many hits are doing it properly. And the denominators, are we looking at the correct denominator? And then we need to consider variation by age, socioeconomic group, geography, ethnicity, and so on. So physical accessibility is clearly an issue. When we think about the accessibility of information before the development of clinical information systems, though, this was a set of notes from a hospital, Glasgow Royal Infirmary, in 1984, and you won't be able to see what it says on the front, but it says this must not be handled by patients or unauthorized persons. Clearly, attitudes are changing rapidly over the last 10-20 years, and things are definitely getting better in terms of accessibility. But it's quite interesting that Hippocrates had said a little while ago that the patient must cooperate in fighting disease, but he advised physicians to perform duties calmly and adroitly, concealing most things from the patient. That clearly has changed. When I was young, there used to be an interesting TV program called Dr. Finley's Casebook, and I've got this clip from YouTube, which is quite fun.
Mr. McGrain, where's your husband?
Not in his house.
Into the surgery. Call the farm, Janet.
Doctor! Oh, no!
Come on. Your tongue, woman. Come on. Cut the clothes off.
This is urgent. I can find you didn't listen in, but can I help you?
Well, anyway, you get the idea. So interesting bits of pick out that particular Scottish general practice in the must be in the 60s, were that apart from the fact that the pregnant lady had walked 7 miles to get to her GP, the GP, if you manage to catch the Scottish accent there, says, "Hold your tongue, woman," and of course the Janet, when she's trying to phone the emergency service, was getting no answer, and there's no answering machine. So we might assume that some things have improved, at least a little, in terms of accessibility with the use of information and communication technologies. So ICT's improved, and attitudes to sharing information with patients have changed, and I think improved a lot. So the question then really becomes, how best can we continue to improve access and the uptake of eHealth? One thing that has been tried over the last 20 years is thinking about physical access and whether there's a role for kiosks. And I did a review of kiosk use recently, and we had a webinar on kiosk use. And we asked, really, is there a role for kiosks, that is these freestanding touchscreen computers, in 2008? In the early 90s, when I was developing HealthPoint in Glasgow, certainly there seemed to be a role for them by giving people access to health information in public situations, reach people who wouldn't otherwise have had health information, didn't have access to the internet at that stage. But now, of course, access to the internet has improved considerably. So we ask, is there still a role for it? Well, there may still be a role. In the late 90s, we were doing various randomized controlled trials looking at patient groups using computers, and this one is a picture of somebody using computerized cognitive behavioral therapy in a public library in a computer booth. And of course now most public libraries do have computers, and there still may be a role for that sort of public use of computers. Probably more importantly, though, I think that we now find touchscreen computers and patients using kiosks of various sorts are being integrated into the healthcare process. So I expect that a number of you may have found that at your GP surgery you actually log on with a touchscreen computer. It certainly is the case routinely here. This was in practice in Texas, but a number of the GP system suppliers in the UK also now are starting to offer automatic registration, the same way that you might register for a flight. And as people get used to the idea of using touchscreen computers in the waiting room, we can see various other uses for them. If you look at our webinar archive, you'll find a webinar given by Alan Wenner talking about computer patient interviewing. And in the States, computer patient interviewing now is becoming really quite routine. So people, preferably at home, are undergoing a computer patient interview on the internet before going to see their GP. But those people who haven't got home access can do it on a touchscreen computer in their general practice. So we're hopefully making this type of facility more accessible to patients. Kiosks are also being used in opportunistic screening, so a number of occupational health settings you'll find kiosks such as this one from a company called WellPoint, where people can get information and also get their blood pressure, their body fat, their body mass index measured. So kiosks may have a role, but clearly they need to be in the right place at the right time with the right information. Interestingly, that the NHS Direct tried to do this in the late 1990s, 1990, 2000, and didn't really work at all well. And that's the NHS kiosk is the one on the right hand side there, the blue one. And I think mainly that what they did wrong was they put them in the wrong places, and they made it look too bureaucratic, too corporate. And this sort of technology has to keep up with the way things change, and we now need to have things which are more fun to use, much more in your face, and really more accessible, because you lose accessibility by making it look like a bank cash dispenser. You also need to make sure, of course, that the way that you present information on a kiosk is appropriate. So you can't just take an internet site and stick it on a kiosk. You won't be able to see that, but then nor would you be able to use it if it was on a kiosk. You need to have nice big buttons, nice easy words to use. This is from a system called InfoSalu in the late 90s. So kiosks probably can reach the parts that other methods don't reach, and they will increasingly be built into clinical process, but they're not an internet substitute. So you wouldn't imagine somebody standing at a kiosk in the street, and you do see a number of kiosks in the street, and they're hardly ever used, and browsing the internet. You might go to the library for that, where you can sit down, but you'll use it for a short session, maybe 2 or 3 minutes, doing it for a certain function that you might do, registering as you go into the GP, maybe doing an interview but sitting down, not standing up. And they need to be designed properly, and they don't really form an internet substitute. Another way of trying to make information more accessible is to just making it easier to find. We all know that on the internet now, trying to find the needle in the haystack is becoming more and more difficult. So what ways are there of making the needle bigger and easier to find? What ways are there of making information more relevant to the user? Well, one way of doing this is via tailored information, and I could sort of refer you to, I've done a number of RCTs in tailored information, but 2 in cancer are both published in the BMJ in 1999 and 2006, showing that tailored information was probably quite a good way of making the information more relevant and more often used by patients. You can probably just about see this. This is an example screen from the system as it was in 1998, so 10 years ago now. But the idea was you have fairly large font, and you have the words in yellow, which were hot links to further information, and we gave patients access to their own medical record, their own cancer record, in a cancer centre in Glasgow. And Donald Demo would be able to touch on one of those words and get further information. So what we were doing was we were using the medical record to index and provide a front end to the sort of information that you would now find being provided by Cancer Backup or by other cancer information providers. So as they went from the next screen here is showing, you may not be able to read it, but it says your prostate cancer is described in medical words as being grade 2+3, localized adenocarcinoma, and so on, and then people would touch on those words and gradually move from the specific to the general. And that approach has shown that people were more likely to find this useful. We also found that the paper version of this type of information was more likely to be shared to a confidant than shown to another. So if you have tailored information, particularly tailored using the medical record, it's much more likely to be shared with somebody else, and that approach is another way really of making the information more accessible. Another point I just want to go on to now is the idea of anonymity and continuity of care and accessibility in that sense. So one of the things that you read about a lot in the literature is that people want continuity of care, and there's a lot of literature about continuity of care and the relationship between the patient and the GP. And actually some patients would rather be anonymous and shop around for their health care or advice. So there is some sort of conflict there, because there is a trade-off. In some cases you do want continuity, in other cases you might want to go elsewhere. But anonymity and the availability of both health information and access to services through telephone or through the internet does play an important role. If we consider, for example, care in mental health, for mental health problems, there are a number of studies where you can find that lack of anonymity is a problem and a barrier to access. So in rural Australia, adolescents had problems accessing psychological help for mental health problems because of the fact that it was a small community. They lacked anonymity. If you can put that onto the internet, it actually can increase accessibility. So in that sense, EHealth can reach the parts that others don't reach, at least in mental health. One particular website that you may have come across is this one here. It's called Living Life to the Full, which is cognitive behavioural therapy for people with depression. It's been developed by somebody called Chris Williams, a psychiatrist in Glasgow, and you have about 50 or 55 people a day log on to this website and get help with their depression through computerized cognitive behavioural therapy online whenever they want it, and anonymous. With Chris Williams and Sito Marambo, who's in the chat room, and others, we did a small study of supporting participants in Living Life to the Full in August last year, and we invited people who are registering Living Life to the Full over a 10-day period, and we looked at how they might want to be supported in their use, because one of the things that people have found about cognitive behavioural therapy is that it's quite good. It helps a lot if you can give people motivational support to carry on with doing the program, whether it's a face-to-face or a book format of cognitive behavioural therapy or online format of. So we tried looking at chat room support for participants, and the participants again emphasised that anonymity was very important in their use of the internet. One person said, "I struggle to tell people how I really feel, and as it was not face-to-face, almost enjoyed the anonymity of it." And interestingly, of 4 out of 21 people that we asked if they wanted their GP to know about it, said no, they did not want their GP to know about their use of Living Life to the Full. So here we see anonymity and use of the internet helping to improve accessibility of health services. Another person said, "I don't want it to affect my critical illness income protection, and so I'm having confidential counselling to try and deal with my stress and anxiety rather than anything through the GP. As it is caused by work generally, and I work in the NHS, it may not be the best thing to let people know officially, as somehow it may affect my job reputation. Ridiculous, but true." And I think a number of people will find that that is the case, that they will go to the internet or other anonymous services for mental health support when they wouldn't go to a face-to-face situation. It's also quite well known that anonymity in giving a clinical or social history may improve the honesty of people in certain aspects of the history. So computer interviewing of patients about alcohol, drugs, sexual health may get more answers and more honest answers than if you do it face to face. The study just quoted at the bottom of that slide there shows a study at Boston University where they surveyed 4,000 new students and got a 55% response rate about their alcohol habits. I think if you tried doing that in a non-anonymous way, you wouldn't get anywhere near the response rate. My colleague Maged Boulos, I don't know if he's in the chat room or not today, but he's set up a website, a location, an island within Second Life, which is a virtual world about sexual health, and within that they have used that to give seminars about sexual health. So for example, this was a number of avatars which represent people attending a seminar on sexual health and disability, and the presenter of that particular seminar, Corey Silverberg, commented that one of the things that were most interesting to me was that the turnout for the talk was much higher than it would have been in real life, as getting people out to talk about sex and disability is challenging for a number of reasons. So you can see that anonymity and use of the internet may improve accessibility for certain conditions, particularly those things which people get embarrassed about. And when we consider some of these terms like connectedness versus anonymity, it's quite difficult to know exactly quite what they mean. I can't even say it. Anonymity is not actually a black and white concept. It's not an on or off, same as connectedness isn't. If you can see and hear me now, But if you didn't know my name or who I was, I would just be a talking head on the internet. You may feel reasonably connected to me because you can see me and you can see that I'm looking at you, or trying to look at the camera anyway. But maybe you don't know much about me. So in that sense, I'm still relatively anonymous. What if I distance myself a bit further by having an avatar, as in Second Life? Do I remain anonymous? There's a trade-off between anonymity and connectedness. But perhaps if I really want to be anonymous and get to use and to communicate with people, I actually need to be even more anonymous and hide away in my little corner and just have a text exchange with no continuity of relationship. And I think there's some interesting ideas there about anonymity and pseudonymity. I mean, as in Second Life, you have a pseudonym, you have an avatar, but that avatar then starts to have relationships with other avatars. So it all becomes rather complicated, and I think there's an area for further research looking at anonymity and pseudonymity and its impact on connectedness within internet communication. Which brings me on to mention a study which is being led by Christabel Owens. Tamsin Ford was on there. I think Siobhan was in the chat room earlier on. I saw number of people. I'm one of a group who are taking part in this study, which is about online communities in public and professional health education, where we're intending to have people who self-harm in the same online discussion forum along with professionals or students to see how people communicate online. This project was funded by the Research for Innovation, Speculation and Creativity Risk Programme, and it was one of 7 projects funded in the first round. And the idea here is that when people first started talking about smoking, for example, you remember that the first thing was just inform people that smoking is bad for your health. But then later on, people realised that you actually had to go and look at health promotion and community development. I think if those of you who've been watching the Jamie Oliver programme on diet change, I think it's on tonight, 9 o'clock, don't miss it, should be really good, will realise the same thing, that it's not just enough to tell people that these foods are bad for you. You've got to go out there and you try and engage with them. Well, the same thing is what we're trying to do in an online environment here in self-harm. How can we get professionals engaging with those people who self-harm, and to learn what it's like, why people self-harm and what it means to them, and to see if you can actually persuade people, but in an engaged sort of way, in the same way that Jamie Oliver's trying to change Rotherham's diet. So we think that the internet can be used to try and reach out, not just to provide information, but also by joining social networks and getting to places that traditional e-health methods won't reach. So if you want to make healthcare and health information accessible, we need to do more than just provide good quality information on NHS Direct, although that of course is important as well. So I've been giving a few examples here about how eHealth reaches the parts that others don't reach. I've given you a few examples from the University of Plymouth. We've got some examples of studies of social connection. I just mentioned some things to do with education and telecare. It's fairly obvious, but clearly things to do with telecare will reach parts that others don't reach. And there are numerous examples from the simple, and the most simple telecare application is the community alarms. There are over 1 million people who have community alarms where people can pull the alarm and then they speak to somebody to help them if they're in a problem. My mother has one in her apartments in Plymouth, and this is the simplest form of telecare. Going to the more sophisticated one, again, my colleague Maged Boulos is part of a European project where they're looking at wearable devices which will tell people if people are experiencing any problems. The objective of this study is to have a wearable device which can measure specific vital signs of a healthy older person, to detect falls and to communicate automatically in real time with his or her caregiver in case of an emergency, wherever the old person happens to be, at home or outside. So clearly, if that sort of thing works, it does make healthcare accessible. Think back to Janet in Dr. Finley's trying to get through to the emergency services. We can also have examples of, this is a study that's just starting, which is a collaboration between the University of Plymouth, UWE, Bournemouth, Wales and others, being led by my colleague Catherine Hennessy, which is looking at older people in rural areas, and it's a study of connectivity amongst older people in rural areas, including the use of ICT. And one particular part of it, which I'm responsible for, is looking at to see if internet connection between older people in southwest England, Wales and the USA will work, and how we can use it to engage between those different groups. And there are interesting issues, not only just the technology, but also whether the cultural differences between southwest England, Wales and east coast USA and older people will be barriers to communication. Can of course also use this for distant education. I know that Rashid Kashani, who's a new distant PhD student in Edmonton in Canada, is in the chat room. We've had a student, Philip Abdul Malik, who's been a distant PhD student for a long time. So in terms of education, health education and professional education, the internet of course makes things more accessible, so he's able to carry on with his PhD without travelling here too often. And tomorrow I'm going to be starting a postgraduate module by interactive webcasting, and I know a number of the people who are going to be on that module are in the chat room today. So just going back to the start, the number of examples there, how it's clear that the internet and e-health does make a number of things more accessible: telecare, information, education. But also we need to always remember that there are differences by age, maybe differences by socioeconomic group, by ethnicity and so on, so that we need to remember that internet access varies by age, and we should always strive to improve accessibility at all time. If just going back to that, just go back a minute to that gap there. If you look at the bottom line there, the 65 plus, in 10 to 15 years time, the people who are currently 45 to 54, which is the third line down, who have an access at about 70 to 80% with internet access, they will be the 65 plus. So there will be a cohort effect, and eventually most people over 65 will have access to the internet. But probably as the current cohorts age, although their internet use will increase, because you're unlikely to lose internet use, we might find that some other new technology comes along, maybe something called Web 2 or Web 3 or Web 7 or something else, semantic web, will develop that will perhaps also have an age gap on accessibility. So there is always likely to be an age gap on accessibility. So let's move on into the conclusion and the discussion. And I'm going to set the cat amongst the pigeons a little bit here. E-health can certainly reach parts that others don't reach, but I think we need to be aware of e-health accessibility issues and not accept the hype and the misleading statistics such as are bandied around by the various speakers in the technophiles, the mobile phone operators and so on. So we need to strive to make e-health more accessible, both physically and personally. And there comes a question, the last question on this slide, have a look at it. Is there a time when we should not use methods because not all can access them? If you think of the sort of some of the real life equivalents here, people would say, well, we don't want to put a supermarket outside of town because although it may be cost effective, not everybody can access it, and it will actually reduce accessibility for people who haven't got cars. So should we do the same for eHealth? Those of you who are in the UK will know that there is something called the Special Educational Needs and Disability Act, SENDA, and this provides, quite rightly, for the legal rights for disabled students in pre and post education not to be discriminated against. And this means it's unlawful for organisations to treat a disabled person less favourably than a non-disabled. All organisations are required to take reasonable steps to prevent that disadvantage. So it means that the provision of materials has to be provided in other formats. And if you'll go back, when you go back out again of this webcast, you'll see that one of the things that we do is we say that if anybody wants this materials today in written formats, we will strive to give it to you. But clearly somebody who relies on a screen reader won't be able to read properly those slides there, because that's not the way the technology works. So we are probably against the SENDA guidelines. We have to try and take reasonable steps. So what are reasonable steps? We've certainly had discussions with some people at the university who would suggest that we shouldn't do webcasting because it doesn't comply with SENDA. Is that the case? If not everyone can access a particular new format, such as webcasting, such as Second Life, such as some other new thing that's coming along, should we stop it? Alternatively, how much should you spend on e-equity compared to cost effectiveness for the majority? When you look at most studies of cost and health services, there's often the economic view of it will be to look at the marginal cost for effectiveness. But what about e-equity? How much should you spend on ensuring equity in the online environment? There's quite a few people logged in, so I'm suggesting that we break out into groups, because otherwise there'll be too many people in the one place. So can I ask some of you to go to the kitchen, some of you to go to the hall, and some of you to go to the ballroom, and what you do is you type in the chat room down the bottom there, you type /room space kitchen or /room space hall and /room space ballroom. And some of you can stay where you are. Note that you do have to type that exactly. If you don't, no, there's no space before or after the slash. There is a space after the word room. And I'm wanting to know what your views are about this. Is there a time when we should not use methods because not all can access them? How much should we spend on improving equity of access? Actually, what I'm going to do is I'm going to write those two questions up because I didn't make it very clear. Let me just do that online right now. So those are the two. Please go into, either stay where you are or go into one of the other chat rooms, kitchen, hall or ballroom, and see what other people think about those two particular topics. Also, if you have any questions for me, type them in the chat room and I'll come back into this video window in about 10 minutes, 10 to 15 minutes to sum up and to the chat and to answer any further questions. Okay, well, I'm going to sort of just come back into the video window now because it's 5 to 4 roughly, British time, and Rashid's probably got to get off to work, and Smita's probably got to go to bed. I'm not sure what time it is there. No, maybe about 7 o'clock. No, it's too early for bed yet. I'm sure other people have got to get off with other things. There's just meant to be a taster to think about some of the issues to do with accessibility. I don't think either the main room or the kitchen reached any major conclusions, but I think there's some issues to think about. I think one of the things that I particularly like to leave you with, in a way, was this this idea that I'm just going to switch that one over. Technology is related to age, and you know, don't listen to people who tell you that there are more than 100% of the population with mobile phones. Only 42% of those people over 75 have got mobile phones. We do need to consider access, and whether it's access for the old, access for the disabled, access for the poor, access for the technologically illiterate. How much you spend on it is a difficult question, and I don't think it's. I noticed Katrina, I think, said she didn't think anybody ever considered that in EHealth Direct. I don't think probably people have explicitly considered how much should you spend on equity. Very socialist sort of idea, isn't it? But then there you are. So thank you very much for your participation. If anybody wants a copy of the chat transcript, I can send it to you. So down in the bottom right hand corner over there, you'll find my contact names, or I'm ray.jones at Plymouth AC UK. If you want a copy of the chat transcript, which we automatically record, I can send it to you. The video bit with the PowerPoint should be available on the archive fairly soon, within a few days or so, hopefully. So thanks very much for your participation, and goodbye. I'll leave you with some more music, I guess. Bye bye.